I was having neurosurgery to place a shunt, and then they rejected and became infected. This time with MSSA. This infection actually was the worst case of sepsis for me, and put me in the ICU for a couple of weeks in the neuro ICU because the MSSA had gone to my brain and was in my brain, my lungs, my heart, of course, blood. And they had to do intrathecal vancomycin into my brain, where they drilled a little hole, put a tube in, and dripped vanc into my brain literally every morning. So again, at that point, I was not able to work, and I was looking more at having a lifelong disability. I was lucky in a way, acknowledging the accommodations that can be made to make your life a little easier and not feel guilty for asking for those accommodations. I think that's another real big issue, is the guilt of saying, I need help, because I'm always the one offering help. Why do I need it now? I'm the giver, I'm not the taker. But now it's, yeah, I do need help.
Welcome to Life as a Patient Doctor. I'm your host, Dr. Stephanie Moss, navigating life as a patient and a medical doctor. Walk alongside me as I reflect on the challenges and triumphs and lessons I've learned undergoing medical education with invisible disabilities. Join me as I interview other doctors, students, and healthcare workers on their own journeys. Listen to their unique stories on how they balance their health while caring for others in the health profession. Welcome, everyone. Today, I have a very special guest. I am interviewing Elizabeth, who has been working and volunteering as a migraine advocate for over 5 years. A migraine patient since about the age of 6, Elizabeth became interested in medicine. She obtained her BSN from Seattle University, and Elizabeth has worked in a variety of settings, both in and outpatient, but became increasingly interested in migraine disease. She returned to school for her Master's of Science in Nursing Education in hopes of teaching the next generation of nursing students. Her migraine story became more complex when Elizabeth was diagnosed with intracranial hypertension, or IH. IH is a rare headache disorder affecting approximately 1 in 100,000 people. With this diagnosis came a number of neurosurgeries and procedures. Despite the setbacks this new diagnosis brings, she continues to act as a fierce patient advocate. Elizabeth is a member of the National Headache Foundation Patient Leadership Council. She is also an administrator and moderator for the Chronic Migraine Awareness Facebook page, and she is a 3-time participant in Headache on the Hill, where she advocates for the needs of all migraine and cluster headache patients. Elizabeth also volunteers with the U.S. Pain Foundation and was profiled in their publication, Invisible Podcast. When Elizabeth is not advocating or learning, she loves to travel, and she can be found on Twitter and Instagram at Wired Nerves. Thank you so much, Elizabeth, for being here today.
Thank you for that wonderful introduction. I appreciate it, Stephanie.
You're very welcome. I would love to hear a little bit more of your story and your background into medicine.
Yeah, I went into nursing right after high school, so right after my bachelor's degree. I knew that I wanted to go into healthcare from a very young age. It was teetering between PA, NP, RN, in that realm. I had always had migraines. I had been a migraine patient since about the age of 6. I was diagnosed. At that point, they were episodic migraines, so I was getting probably under 10 a month. And then as I entered high school, my migraines became chronic, which meant 15 or more a month. At that point, we started aggressive treatments, and I was on medications and procedures like Botox. I also had some experimental procedures done because my migraines were impacting the quality of my life so much, where I actually had a occipital nerve stimulator placed, which is basically a spinal cord stimulator flipped, and the leads are attached to your occipital nerves. Unfortunately, with that, procedure came my first foray into some disability aspects of working as a nurse in healthcare when the device ended up becoming infected with MRSA. When that happened, I was placed on IV antibiotics for a period of a few months and was not able to work during that time. I had to have surgery to do an emergency explant of the device and get it removed as quickly as possible because I was completely septic with the MRSA. We did the months of antibiotics. And like I said, during the time, I wasn't able to work. And that's when I first noticed that nurses aren't the greatest at being kind to each other when we face health problems. That was the first job actually that I lost because of being sick and disabled. I had run out of FMLA time. And at the time I was working as a case manager for a large insurance company. And they basically told me if FMLA is out, you have no options. Unfortunately, we're not going to be able to continue your employment because you are sick. I'm in a state that's a right to work state, so we don't have unions and things like that available to us. And so I was basically fired from that job. Thank goodness for nursing, it's not difficult to get more jobs. We have a lot of variety of what we can do. So I had the stimulator removed, and actually the stimulator had been relatively helpful. So at the time I was told that I could get another stimulator placed because it did help. And they would do lots of antibiotics and MRSA wouldn't be an issue. That one lasted about 6 months before it became infected with MRSA. So I became septic again. And it was at this point that I knew I wouldn't be able to hold down a job for the foreseeable future. During this time, I was also diagnosed as having idiopathic intracranial hypertension, which is another rare headache disease that is extremely disabling because for me, the medications weren't working to control it. So I was having neurosurgery to place a shunt. And then my body didn't like the shunts. They rejected and became infected and were controlling the condition, but it was also causing complications. The worst complication that I had from the shunt was actually, again, another infection, this time with MSSA. This infection actually was the worst case of sepsis for me, put me in the ICU for a couple of weeks in the neuro ICU because the MSSA had gone to my brain and was in my brain, my lungs, my heart, of course, blood. And they had to do intrathecal vancomycin into my brain, where they drilled a little hole, put a tube in, and dripped vanc into my brain literally every morning. So again, at that point, I was not able to work, and I was looking more at having a lifelong disability. I was lucky in a way. I went through and went on SSDI early in my diagnosis. I went when I started having the brain surgeries and went on SSDI and then did some programs with them where I went back to work for a little while. Then I would get sick and off work. But anyway, I was able to get approved for SSDI. And then eventually I worked at a job where I was able to get long-term disability coverage. And so I worked at that job for a little over a year and a half and was able to use my LTD, my long-term disability, to help supplement my SSDI. In between, nothing is static and as easy as it seems. One of the issues with intracranial hypertension is that you get a lot of spinal taps, especially when like 12, 13 years ago, serial spinal taps were a treatment. They are not anymore, but at the time they were. I unfortunately had a spinal tap that I developed a leak from, where the hole in the dura that was made to extract this spinal fluid wouldn't close. And so they did what was called a blood patch, which is where blood was taken from my arm, put into a syringe, and then directly injected back into my spine outside the dura to create a blood patch, which is basically like a clot over the hole so that it would stop the CSF from leaking from the hole. Unfortunately, during that procedure, I had a physician do it, and he injected my blood instead of outside the dura. He proceeded to inject it inside the dura directly on the spinal cord. When that occurred, it created a condition called adhesive arachnoiditis, which is permanent and progressive cauda equina. So, with this procedure and the complications that arose, this occurred about 8 years ago now. My nerves off the cauda equina have all clumped together, and they are going down and clumping further down from like L4, L5 down. The clumping is progressive, the condition is progressive, and will eventually, according to neurosurgeons and neurologists, probably put me in a wheelchair. I'm using mobility aids now, such as a walker when needed, and having a lot of complications from the arachnoiditis. Unfortunately, there's no treatment, no cure, no surgery. Medication and palliative care is the only option that I have in terms of treatment. Needless to say, dealing with two major illnesses and trying to work, trying to go to school, and then having to get disability has been a major impact on my life. I obtained my master's and thought maybe I can do some teaching, at least part time. And literally, I got a job interview, accepted a position as a teacher, and the next day I had to go in for emergency brain surgery. Unfortunately, working is no longer in my cards, but I am able to still do my volunteer work, which has become increasingly important to me. So sorry for the long diatribe, but it's a unique situation that I'm in.
Oh my goodness. I don't know where to start. My heart is bleeding. My husband just called me a bleeding heart. And I think that I can't imagine all that you've been through. Oh my God. So much pain, so many years. And I am so sorry that
Thank you. Yeah.
that you've lived this, but I am so proud of you for using all these experiences to really strengthen you and to, oh my goodness, I'm crying. You can tell the perseverance that you've been through, like going through those nasty infections that are scary of sepsis and then the ICU. So many people would have given up. What has led you to keep going? What has been your motivator to get to where you are?
Honestly, I want people to learn from my mistakes because I was very apt to just follow the advice of doctors without doing my own research and learning more about the condition. I think I really feel like I do have a calling to teach and to do that advocacy work. That's what I love. My jobs that I did a lot in nursing is I had a couple of case management positions that I adored. That was my jam because I was able to work with somebody over a long-term basis and help them get the things that they need, whether it be medications or treatments and things like that. And I really was able to get a bond to my patients that I was working with this way. And I feel that my experience as a nurse and as a case manager has been invaluable to helping me progress and helping me get the treatment that I need, because a lot of times I'm fighting for treatment versus it being handed to me and doctors saying, oh, this should be your next type of doctor to see. I don't have that because there is nobody to see. I think that learning that I need to really advocate for myself, I can help others advocate for themselves. And then I've also learned over the past year and a half or so that for me, having an advocate and my partner, now he is my ultimate advocate and he goes with me to appointments and can really show what effect my conditions are having on us as partners, as well as me as a person, just knowing what my pain level is. And he can chime in and say, I'm noticing that her pain really goes up between the hours of this and this, or his observations. Up until then, I hadn't had anybody really helping me. And I was doing everything on my own. But having a new added partner has just been absolutely amazing for me and really advocating for my needs because I'm so concerned about others. Sometimes I would just forget that I needed care too.
Yes, I love what you said right there. Like your passion for advocating for others allowed you to how to be able to advocate for yourself. I think that is such a challenge
Mhm.
that all health professionals, everyone in the healthcare field, that's why we go in because we want to help others. But then
Mhm.
we need to learn how to help ourselves and advocate for yourself. I love
Yeah, we can't keep other people afloat if we're not afloat. If we're sinking, we're not going to be able to help somebody else. So to keep yourself above that sinking feeling, I think is really important too. And knowing your limits. This year, my back has gotten worse and travel is becoming more and more difficult for me, which is really hard. So I had to make the decision this year not to go to DC and do Headache on the Hill, which is a really big advocacy program that I love participating in. But I also know physically it would be really difficult for me to do. So having to create limits has been really important too for me.
how has those limits, I'm guessing that also means like being able to say no to others. Do you have
Mhm.
any advice on how to share your boundaries with others when these different health conditions come up?
Yeah, I had, especially with the migraines, I had a lot of things that could be done in the workplace, a lot of little things that would help me. And working with HR and getting accommodations. Like my migraines are set off by fragrance. Fragrance is a huge thing for me. Most hospitals are fragrance free. So that's really good for me. Acknowledging the accommodations that can be made to make your life a little easier and not feel guilty for asking for those accommodations. I think that's another real big issue is the guilt of saying I need help because I'm always the one offering help. Why do I need it now? I'm the giver, I'm not the taker. But now it's, yeah, I do need help.
I love that. I'm the giver, not the taker. That is very hard to do in medicine. And I'm so glad that you've developed that boundary for yourself and being able to state those boundaries to HR and accommodations. One of the things I've been talking to individuals about is accommodations and disclosures. Did you ever
Mm-hmm.
state those before you applied, or where was it in your journey of working or going to school? When did that disclosure and request for accommodations come up for you?
It came up when it became an issue for me. I didn't bring it up like in university and things like that before the fact. It would be more as things progressed, I needed A, B, and C done to make things more workable for me. But then as I progressed, and especially over the past, like my last position, when they ask you on the HR forms when you're being hired, do you have a disability? I marked yes. And that's a big step because it was disclosing to HR. Is this a right move to make? Should I tell them? Because there's always a risk of repercussions or ramifications coming through by HR. So I didn't want to put a target on my head either. But I think that was a big acknowledgement on my part to say, okay, this is something in my life that's important and needs to be addressed. And I'm the only one that can bring it to their attention. They're not going to magically know what's going on. So it is like my responsibility, I think, as a employee and as a nurse to say, yeah, this is what's going on, and not give them the whole like spiel, but at least say if you expect accommodations, at least letting them know what that might be. And most, I would say, HR when I've done that has been more than happy to work with me. I've never faced any repercussions from stating my need for accommodations or my disability.
That is really great to hear. There are a lot of people that have a lot of fear on that initial disclosure
Mm-hmm.
of exactly what you said, of the repercussions, of the bias.
Mm-hmm.
So I'm so glad to
Mm-hmm.
hear the positive impact that
Mm-hmm.
can have on your life. When you've interacted with patients, how has
Mm-hmm.
your unique perspective as a patient impacted how you've also worked with patients?
Oh, it's totally changed my perspective. I think that I am a better rounded nurse because I have experienced care. I know what it's like to be in the hospital. I know like some of the things that happen, and I just get it a little bit more than some other people may. And also some subjects that other people may find taboo are the ones that I want to delve right into, especially with chronic pain and medications. That's a really big issue with the opioid crisis, and it's also a big issue for chronic pain patients. because there is a lot of fear within the chronic pain community that their medications will be cut off. I think that's a really big area of advocacy too that I've moved into, to say that chronic pain does exist. And unfortunately, at this point in time, sometimes the only treatment is narcotic or opiate medication.
That's a really good point. I'm glad you brought that up. I didn't know that was the fear.
Oh,
There,
yeah.
I know that there's a fear of being ignored for the pain
Uh-huh.
or not treated, but the concept of just your treatment being stopped, that's a really helpful perspective.
It's huge, especially within the thoracic community where pain, there's times of literally of writhing in pain because it's so severe. It feels like my spine is exploding from the inside out. And then I have pain going down my legs and I fall and things like that. And the fear of meds being taken away, or a pharmacy's not having the med, or a pharmacist not willing to dispense a med, are all fears that are very legitimate within the pain community. When I went to nursing school, I graduated in '03, and we were always taught that pain should be looked at as a vital sign. Then that was right before kind of the opiate crisis really began. And now that's not even like a thing in the nursing community. That's not, they don't look at pain as a vital sign. They look at it as a way to assess pain, but not necessarily an accurate. I think there's a lot of times that people think like on the pain scale and things like that people are exaggerating and like they're trying to manipulate the system or trying to, there's just so many negative connotations surrounding chronic pain and the healthcare community. I think that the pendulum has just swung back from thinking, oh, pain is like the fifth vital, to now we're not even going to address pain and you're going to have brain surgery with Tylenol, which has happened to me.
Oh God. Oh, I can't even.
Yeah,
I've never
yeah.
heard
So
that statement of pain as a vital sign. Can you talk about what you learned about that?
yeah, we learned that the 1 to 10 scale, that we should trust what the patient is saying, that we're not the ones to judge. And if they say their pain is like a 9 or a 10, for them, it is. It's not our place to pass judgment or to say, you're doing this, so obviously you can't be in a 9 out of 10 pain because you're talking on the phone. When you're in chronic pain, your whole like 1 to 10 scale gets thrown out the door and revamped because of what you're experiencing over a very long period of time. You can almost get acclimated in a way to the pain. And so you can do things and function at a high level of pain. I know when I had one of my brain surgeries for the shunt, I was in the neuro ICU, and this was probably about 9, 10 years ago. And I was working on my master's thesis in the ICU. And I was still having massive amounts of pain, but I was able to do that. So somebody coming into the room may say, oh, she's working on her computer, she must not be in any pain, when in fact, it was a way for me to distract myself and to try to ignore and push away the pain, even though I'm still experiencing it.
Yes, very much. I like that of distraction because
Yeah.
that's what you have to do when you're in pain.
Hmm.
You have to use whatever tools you have available to really not just focus on it because it can get worse.
Yeah. Wallowing is really easy to do. It's really easy to get sucked up into your pain. Yeah, it's hard.
No, I very much appreciate that. I also have chronic pain myself, so I
Mhm.
understand that. Going with that, do you have any recommendations on or any thoughts on disclosure with patients? Have you ever done it? Do you think it's appropriate? What are your thoughts on it?
It's a hard one. I think with certain patients, it's appropriate. Not everyone, obviously, but I've had a couple of patients with intracranial hypertension that I did some case management for. And I let them know that I too had that condition because there is a sense of loneliness and isolation a lot of times from a rare disease diagnosis. And I would give them resources that have worked for me and books that have worked that I've read that pertain to the condition and things like that. But with my general patients, I wouldn't discuss what was going on, obviously. There were those few that you go towards and you do get a different relationship. And I know that there's a great headache specialist here in Arizona, and she tells her patients that she gets migraine too. So she can, I like that because it puts her at a level where it's like, there's always this respect for physicians. So maybe it puts it more at a person, like you can relate to her a little bit more as a person and not just as a physician or as your doctor. So I like that.
Thank you so much for sharing that. That is really helpful to hear because that's something I've been trying to ask more people to get their perspective of, especially when we're talking about also being in the healthcare field and having
Mhm.
this separation of provider or healthcare worker and patient. So
Mhm.
that is really helpful
Mhm.
to hear. And that another actually doctor that you worked with even shared that,
Mhm.
and it had a positive impact on your relationship. I
Mhm.
think that's
Mhm.
powerful to share. Elizabeth, you've shared so much already, but I also want to recognize the time and respect your time. Do you have any final? I'm going to ask you like two different things. Advice for individuals who have disabilities in healthcare, but then also my husband's a neurologist or he's an intern neurologist.
Oh,
So he's
oh.
gonna be very excited. He is actually really interested in the neuro ICU. So I would love for
Mm.
you to provide any advice to him or any other neurologists, advice for them, and then also separately advice for just other healthcare providers who do have disabilities. So sorry,
Sure. No,
those two last things.
I think that a really big thing that healthcare providers who do have chronic illness can learn to relate on a different level with patients. And it may not have to be vocalized that they understand on that level, but just internally, I think having the knowledge that, okay, I've been a patient, I've experienced A, B, C, and D. So maybe I can give the patient some more personalized advice about what they might be facing. And I also think, again, asking for accommodations at a job really is crucial because that's your a job is your livelihood. A job is where you spend so much of your life, and it's such a big aspect of who you are. To be fully understood and fully supported by your employer, I think is extremely important. And by being open with your accommodations and your needs, I think that can be more easily obtained. Now, for your husband in the neuro ICU, it is extremely traumatic for the patient. At least it was for me. After that stay that I had with the MSSA in the brain, I was diagnosed with medical PTSD because I was in a state where in the ICU, I wasn't sleeping. I was averaging 45 minutes a day of sleep, and that was it because I was in so much pain and they were doing so many procedures and fully conscious, no sedatives, no benzos, nothing like that. And that was actually, I think, probably more harmful than a lot of things that I've been through was not being appropriately. I would have loved to have somebody come in who maybe was a therapist or a social worker that could listen because the stress of being in the ICU and of being awake is incredible. And I had no clue how hard it was going to be until I got in there. And not having a person to talk to about my experience, I think was really detrimental at the time to my recovery.
That is really good to know, and I'm so sorry that you went through that. And
Yeah.
it's been horrible and scary, it sounds like.
Yeah, very scary. Yeah, when you're told to start filling out your medical power of attorney and getting that all arranged, that's when it becomes real.
Oh, wow. Okay. That is helpful to know of advocating for those case managers, for those therapists.
Hmm.
I know at our hospital, we have chaplains for that,
Yeah.
chaplains or palliative medicine to come. So that is a good reminder for
Hmm.
individuals in the ICU to also have that emotional support presence.
Absolutely. Use the resources that are available. And even the ones that are forgotten about, like the chaplain or a social worker, not always going to be the first thing on your forefront of your brain when it comes to getting a patient better. But you can't ignore the mental and psychiatric and psychological aspects of your care as well. It's not all physical.
Yes. Oh, very much. That is my passion of, yes, individuals who are in health, especially individuals who are experiencing significant medical illnesses. That's when they need the most emotional support.
Absolutely.
Like you said, there's a connection, and the mental health has to be addressed and not ignored. And that's how you can even help with treatment. It should be part of the treatment plan.
Absolutely, 100%.
So I'm gonna close off. If anyone wants to contact Elizabeth, you want to share your contact information?
Sure. I'm at Wired Nerves through Insta and Twitter, X, and you can find me on there. Usually just posting fun things. And like I said, I do love to travel. So I always post things about traveling with a disability. So another topic that's interesting.
Ooh, yeah, we're gonna have to talk about that on another. Interesting. I love that. To be continued. So yes,
Yes.
follow Elizabeth. Thank you so much for listening to the podcast, Life as a Patient Doctor. I very much appreciate Elizabeth taking the time and being very vulnerable about her story and her disabilities. She talked about starting off from just a young child having migraines and those progressing to then having more chronic migraines and really impacting her day to day, into a point that she developed intracranial hypertension and had to go through multiple medical procedures to treat the pain, and also neurosurgical interventions, and having complications from those interventions, from the shunt, having sepsis, and how that had a lasting impact on her. Thank her so much for talking about patients with chronic pain, as she is also a patient, with her experience in advocating that other patients with chronic pain have their own experience, and we as health providers should trust them. Whatever number that they say, it is their number. I love the concept of treating pain as another vital sign. You're not going to say, oh, this heart rate isn't 101. That's not right. No, 101. Same thing. If a patient has a 9 out of 10, they have a 9 out of 10, and to not judge how they're coping with their pain. We also talked about the mental health impact that these health conditions can have, the isolation that patients have in the hospital, especially in the ICU, where they can be having procedures, and it's so important to connect them with different healthcare, different social works or therapists to help them process it. So it's important to use the resources you have. And I would even add in, if you're a physician and if you're in the ICU, add in mental health as an additional part of your plan. When you go through the organ systems, make sure you add in mental health. That's my own little extra thought. But thank you, Elizabeth, so much again for all the listeners that have been here and supporting. If you haven't already, click follow wherever you're listening to, whether that's YouTube, Spotify, Apple, wherever you're listening to your podcast. Click subscribe, and also share it with one other person, because I love to share this advocacy and let people know they're not alone. That's really my motivation, that everyone struggles with their health at some point in their lives, and there are people out there that hopefully we can share through this podcast that have persevered and have wisdom that they can provide to others who are struggling. So thank you, everyone, so much, and see you all next time. Thank you, Elizabeth.
Thank you, Stephanie.